Imagine going in for, just a routine 20-minute outpatient procedure. You are there to fix a little stress incontinence, or maybe you're getting a quick laser treatment to rejuvenate vaginal tissue.
Right, something super common.
Exactly. You totally expect to be home for lunch. But instead, because of one tiny invisible oversight during your preoperative workup, you end up in the ICU a few days later fighting off full-blown sepsis.
Wow.
Or, you're back in the operating room having a permanent implant surgically carved out of your body.
I mean, it sounds like it's extreme worst case scenario, but in the realm of urology and urogynecology, that escalation can happen with terrifying speed.
It's wild.
It really is. If a clinician misses a pre-existing infection, well, we're looking at a diagnostic challenge today that sits right at the intersection of advanced outpatient technology and, frankly, baseline human biology.
Welcome to today's deep dive. We are so thrilled to have you with us. Our mission for you today is to uncover exactly how clinicians navigate this incredibly complex medical minefield.
Yeah, the screening process.
Right, screening for active urinary tract infections, UTIs, before they perform these invasive pelvic procedures. And we are focusing our lens on two very common treatments. First, urethral bulking, which uses hydrogels like Bulkamid or macroplastique. And second, vaginal laser therapies, which use fractional CO2 or ERYAG lasers like the Mona Lisa Touch.
Both of these interventions have completely revolutionized outpatient care, Or urethral bulking essentially reinforces the urethra to stop urine leakage, and the lasers, they regenerate tissue elasticity and moisture.
Which is amazing for patients.
It's life-changing. But if you read the manufacturer guidelines for any of these devices, you will see a massive, bolded, absolute contraindication, an active urinary tract infection.
Deal breaker.
If the patient has a UTI, the procedure is canceled.
Yeah.
Period.
Okay, let's unpack this because on the surface, it almost feels like an overreaction, right?
I can see that, yeah.
People get UTIs constantly. You feel the urgency, you take a quick antibiotic, drink some cranberry juice, and you move on. Why is an active UTI such a massive, deal-breaking event for a procedure that barely takes 20 minutes?
Well, to understand the sheer panic a UTI induces in a surgeon, we really have to look at the microscopic trauma these procedures inflict on the tissue.
The physical damage.
Exactly. They purposefully breach the mucosal barrier. So let's look at fractional CO2 lasers. The goal is tissue regeneration, and the mechanism for that is controlled damage.
Right.
The device utilizes something called pulse stacking thermal damage.
Wait, pulse stacking. So it's not just like a continuous beam of light then?
No, not at all. It's rapid, sequential laser pulses hitting the exact same microscopic column of tissue over and over. What's fascinating here is that when you stack those pulses, the thermal energy accumulates faster than the tissue's natural thermal relaxation time.
Oh, so the heat literally can't dissipate?
Exactly. It instantly vaporizes the surface cells and creates this deep, microscopic shaft of thermal necrosis, basically dead tissue surrounded by a zone of coagulation. And the body rushes to heal this intentional wound, pumping out collagen.
Okay, but if there is an active bacterial infection present in the vaginal or urinary tract, you just blasted a necrotic highway straight through that protective mucosal lining.
Yep, straight into the underlying vascular bed.
That's terrifying.
You've basically handed the bacteria a VIP pass into the systemic circulation. So a localized, easily manageable bladder infection can suddenly become bacteremia, where bacteria are actively multiplying in the bloodstream.
And that cascades into sepsis.
Right, which is a life-threatening emergency.
Wow. And urethral bulking adds like a completely different mechanical risk, doesn't it?
Oh, totally. With barking, the clinician is threading a rigid cystoscope into the urethra to guide a needle. Just the friction of that metal scope creates micro-scratches along the inflamed lining.
Which is already bad, but worse, you're injecting a foreign hydrogel implant right into that scratched tissue.
Yeah, and that introduces the nightmare of the bacterial biofilm. If you inject a hydrogel like Bulkamid into an environment where an active UTI is raging, those bacteria will immediately gravitate toward that synthetic surface.
They like the hydrogel.
They love it. Once they attach, they begin communicating through a process called quorum sensing, and they secrete an extracellular polymeric substance.
So essentially a microscopic slime shield.
A highly impenetrable slime shield. Once that biofilm encapsulates the hydrogel, the bacteria are effectively protected from the patient's immune system, and, they're largely shielded from systemic antibiotics.
Wow. So macrophages can't eat them, drugs can't reach them.
Nothing works. The implant just becomes this permanent bacterial fortress, constantly seeding new infections.
It's sort of like aerating a lawn while it's covered in toxic weed seeds, right? You're just planting the problem deeper into the tissue.
That is a perfect analogy, yeah. You're guaranteeing a permanent problem, which means the only solution is to send the patient back to the operating room and surgically cut the hydrogel out of the urethral wall.
Explantation.
Right, and that completely defeats the purpose of a minimally invasive outpatient procedure. It is a devastating complication for the patient.
So this is why establishing absolute certainty that the urinary tract is sterile is totally non-negotiable.
Uncompromisingly so.
Okay, so if a single micro scratch or laser pulse can trigger sepsis or a permanent biofilm, the screening process must be foolproof. But I mean, if you've ever sat in an urgent care clinic with a suspected UTI, you know the routine.
Pee in a cup?
Exactly. You pee in a cup, they dip a little plastic stick with colored squares into it, and you have an answer in 30 seconds. So why don't surgeons just use a dipstick in the clinic on the morning of the procedure to prove the coast is clear?
Well, the American Urological Association heavily cautions against relying on urine dipsticks for preoperative screening, specifically because of the biological trick behind how those colored squares actually work.
Wait, trick?
Yeah, they do not detect bacteria directly, they detect the chemical byproducts of bacterial digestion.
Oh, I see. They're looking for waste, not the actual organism.
Right. One of the primary squares on that dipstick tests for nitrites. Our bodies naturally excrete nitrates with an A in our urine from the food we eat. When certain bacteria are present, they utilize an enzyme called nitrate reductase to convert those nitrates into nitrites with an I.
Okay, A to I. Got it.
And the dipstick changes color when it hits the nitrates. But, and this is the kicker, that digestive process takes time. The urine generally needs to pool in the bladder for about 4 hours for the bacteria to produce a detectable threshold of nitrates.
Wait, 4 hours? But we're talking about a patient population seeking treatment for severe stress incontinence. I mean, they leak urine every time they cough or stand up. They aren't holding anything in their bladder for 4 hours.
You nailed it. Or consider the patients who suffer from intense urinary frequency, rushing to the bathroom every 30 minutes.
Right.
The bacteria are absolutely present in the bladder, but the urine is being flushed out so rapidly that the chemical conversion never reaches the threshold, so the dipstick stays its original color.
Giving a false negative. So the surgeon looks at the stick, thinks the urine is sterile, and proceeds to fire a laser or inject a hydrogel right into an active infection. That is terrifying.
It's a huge blind spot.
What about the other squares on the stick, though? Don't they check for white blood cells, too?
They do. They check for leukocyte esterase, which is an enzyme produced by white blood cells. But this marker has a notoriously poor positive predictive value for actual infection.
How so?
Well, a positive result simply indicates pyuria, which is just white blood cells in the urine. That points to inflammation, but
Right.
not necessarily a bacterial infection.
I mean, inflammation could be from anything.
Exactly. If a patient uses a catheter or if they just have poor bladder emptying, the tissue is going to be chronically irritated.
So the dipstick will light up positive for leukocyte esterase, potentially causing a surgeon to cancel a desperately needed procedure over what's essentially a phantom infection.
Right. The diagnostic tool is just entirely mismatched for this specific clinical context.
Okay, so the dipstick is out. It gives false negatives for incontinence patients and false positives for chronic inflammation. What is the actual gold standard to guarantee the surgeon isn't about to cause a systemic infection?
Clinicians must rely on urine MCNS microscopy, culture, and sensitivities. It's a multi-day laboratory process.
All the day.
Yeah, and before they even attempt to grow the bacteria, they examine the raw sample under a microscope to evaluate the quality of the collection itself. One of the primary red flags they look for is a high count of squamous cells.
Squamous cells. Why do those matter?
Well, if the lab sees more than 20 squamous cells per high-power field, the guidelines dictate that the entire sample has to be thrown out. The results are totally meaningless.
Wow, really? Just over 20 cells?
Yep, because a high squamous cell count tells the pathologist that the urine sample washed over the external skin of the perineum or labia during collection.
Oh, so the sample is contaminated with normal, harmless skin flora.
Exactly. And growing that in a petri dish would give you a massive bacterial colony, but it wouldn't reflect what is actually happening inside the sterile environment of the bladder.
Right, so the lab demands a strict, clean catch midstream sample. Assuming they get a good sample, we are now talking about physically incubating bacteria in a lab over several days.
Huh.
From a purely logistical standpoint, this completely changes the timeline.
It really does.
You cannot test the patient in the waiting room.
No, it introduces a massive logistical hurdle. If we look at bodies like the Getting It Right First Time program in the UK or the French Association of Urology, their guidelines are incredibly specific.
What do they say?
They mandate that this MCNS testing must occur 10 to 14 days before the scheduled procedure, which they call the TCI, or to come in date.
So what does this all mean for the patient? 10 to 14 days. If the stakes are this high, why wouldn't a doctor just order the culture like a month in advance during the initial surgical consultation? Just get it out of the way.
Because the urinary tract is a highly dynamic environment. Think of the 14-day window like a security sweep before a high-profile VIP arrives at a building.
Okay, I like that.
If you sweep the building a month in advance, you leave a massive window for a new threat to sneak in undetected. A patient's urine might be perfectly sterile 30 days out, but they could develop a raging UTI just 3 days before the surgery.
Right, you'd completely miss it.
Yeah.
But on the flip side, it's like taking your car in for a brake inspection before a cross-country road trip.
Right, yeah.
You don't do it 6 months in advance, but you also don't do it as you're backing out of the driveway. Because if you do find a threat right then, you have absolutely zero time to neutralize it.
That is the exact clinical rationale. Testing on the morning of surgery leaves no time to react. The 10 to 14-day window is the absolute optimal runway.
The Goldilocks zone.
Yes.
Right.
Because if the lab cultures a pathogen, they move to the S in MCNS sensitivities. They expose that specific bacterial colony to various antibiotic discs in the lab to measure the zone of inhibition.
Essentially seeing which drug annihilates that specific strain most effectively.
Exactly. So if a patient tests positive 12 days before their bulking procedure, they don't lose their surgical slot.
Oh, that's huge.
Shouldn't have to. The surgeon receives a highly specific lab report dictating exactly which antibiotic to use. They can prescribe a targeted 48-hour course of antibiotics, knowing with near absolute certainty that the urine will be sterile by the time the patient arrives on the morning of the procedure.
It's a brilliantly engineered system, honestly. You bypass the chemical flaws of the dipstick, you time the laboratory culture perfectly to avoid those transient infections, you identify the exact biological vulnerability of the bacteria, and you neutralize it before you ever breach the mucosal barrier.
It's very elegant.
It sounds like a closed loop. But this is medicine, and medicine hates a closed loop.
Oh, absolutely.
What happens when the lab culture comes back positive? The petri dish is just overflowing with bacteria, but the patient feels completely fine. No burning, no urgency, no fever.
This raises an important question, and you have just hit on arguably the most contested gray area in modern urology: asymptomatic bacteriuria, or ASB.
The bacteria are present, but the symptoms are not.
Exactly. And our understanding of the bladder has evolved dramatically. I mean, we used to think urine in a healthy person was entirely sterile.
Right. That was the old school thought.
But we now know the urinary tract has its own microbiome. In many patients, particularly older individuals, residents of long-term care facilities, or those with a history of pelvic surgeries, bacteria can colonize the bladder wall without triggering an inflammatory immune response.
So the immune system basically looks at the bacteria, shrugs, and decides they aren't a threat.
Sort of, yeah. The host immune system downregulates the cytokine response, and no inflammation means no pain, no burning, no fever. The patient and the bacteria are existing in a state of commensal harmony.
Okay, so if the patient is living in harmony with this bacteria, what do the guidelines say a surgeon should do if that patient is scheduled for, say, a vaginal laser treatment?
Well, the Infectious Diseases Society of America, the IDSA, has very clear, aggressive guidelines regarding asymptomatic bacteriuria. They strongly advise against treating it.
Really? Leave it alone.
Yes. Pumping a patient full of antibiotics to eradicate harmless, colonized bacteria that isn't causing symptoms is one of the primary drivers of global antibiotic resistance. You are just forcing the bacteria to mutate and survive.
Okay, so the IDSA says leave it alone. That makes sense for global health.
But the IDSA includes one critical caveat. They say, do not treat ASB unless the patient is undergoing an endoscopic urologic procedure associated with mucosal trauma.
Oh, which brings us right back to the cystoscope scratching the urethra and the laser vaporizing the tissue.
Exactly. The urologists are caught in a trap. Do you follow strict antibiotic stewardship and ignore the ASB because the patient feels fine? Or do you preemptively nuke the harmless bacteria because you know you're about to cause thermal and mechanical trauma?
That is a terrible position to be in. What does the data say?
Well, if you turn to the clinical data for an answer, you find massive contradictions.
Of course you do.
Naturally. A landmark multicenter trial out of Sweden analyzed 2,200 patients undergoing various urologic procedures. They tracked the patients who had preoperative ASB, and they found that the presence of that colonized bacteria did not increase the incidence of symptomatic postoperative UTIs.
Wow, okay. So the surgical trauma did not turn the harmless bacteria into a threat? And a sample size of 2,200 patients is incredibly robust. That data strongly suggests you should ignore the ASB and spare the antibiotics.
Right, but then you analyze a different review focused specifically on cystoscopy patients, which is the exact endoscopic instrumentation used to inject bulking agents.
Okay.
That research indicated that when ASB was present preoperatively, the risk of the patient developing a severe symptomatic UTI post-procedure increased over 16-fold.
Wait, 16-fold? That is a staggering increase. How can the literature support a study showing zero increased risk alongside a study showing a 16-fold explosion in risk?
It's messy. It really comes down to varying definitions of mucosal trauma across different surgical cohorts and, the varying virulence of different bacterial strains. The data is so conflicting that clinical trial bodies have realized they need highly targeted answers for these specific outpatient procedures.
So what are they doing about it?
Currently, there are major trials running like those at the University of Miami and the Atlantic Health System investigating the use of prophylactic antibiotics strictly for urethral bulking.
I see. So rather than trying to decipher if a patient's ASB is dangerous or harmless, they're testing the efficacy of just giving everyone a preventative single-dose antibiotic, like Bactrim or Macrobid, right before the procedure.
Exactly. They are randomizing the cohorts. One group receives the prophylactic dose, the other receives nothing, and they track the infection rates.
That's to see what happens.
The goal is to determine if handing out routine antibiotics is genuinely protecting these women from that 16-fold risk of implant infection, or if it is just an outdated defensive practice that's breeding superbugs.
It is incredible to realize that in an era where we can inject biocompatible hydrogels and fire fractional lasers to regenerate tissue, one of the most pressing unresolved questions is simply whether or not to give a patient a single preventative pill.
It's wild, but it perfectly illustrates the tension in modern medicine. You are constantly balancing the immediate, terrifying risk of a surgical complication against the abstract, long-term threat of eroding our global antibiotic arsenal.
Here's where it gets really interesting, because when you step back and look at the whole picture, screening for UTI before these procedures isn't just a matter of checking a box on a pre-op form.
Not at all.
Clinicians are operating in a highly volatile environment. I mean, they have to respect the catastrophic risks of pushing bacteria into the bloodstream or allowing a biofilm to encapsulate an implant. They have to understand the biological mechanisms that make rapid dipsticks dangerously unreliable for incontinent patients. They have to execute a perfectly timed 13-day logistical sweep to culture and neutralize pathogens. And finally, they have to navigate the murky immunology of asymptomatic bacteriuria.
It demands such rigorous clinical judgment. A doctor cannot just treat a laboratory printout. They have to evaluate the specific tissue trauma their instrument will cause, the specific bladder mechanics of the patient in front of them, and synthesize guidelines that occasionally pull them in completely opposite directions.
As we wrap up today's deep dive, I want to leave you with one final kind of mind-bending paradox from the source material.
Oh, this is a good one.
We have spent this entire time establishing that an active UTI is the ultimate deal breaker. The presence of infection absolutely disqualifies a patient from receiving vaginal laser therapies like the Mona Lisa Touch because the thermal necrosis could drive that infection systemic.
Right. It is a hard, non-negotiable contraindication across the entire industry.
Yet if you look at current clinical trial registry, specifically trial NCT 04301-934, researchers are actively testing fractional CO2 vaginal lasers as a cure for recurrent UTIs.
The hypothesis is fascinating from a tissue regeneration standpoint. They believe that by inducing that controlled thermal damage, the laser will rebuild the vaginal epithelium, lower the local pH, and massively increase the colonies of healthy lactobacillus bacteria.
So they want to use the laser to re-engineer the microbiome so it can naturally fight off future infections.
Exactly.
But think about the clinical catch-22 that creates. How will a clinician successfully thread the needle of treating a patient whose primary debilitating problem is constant active infections, when the mere presence of an infection disqualifies them from receiving the exact laser therapy designed to cure them?
It is a brilliant puzzle. It forces us to ask how we safely transition a patient from a state of chronic illness to a state where they are healthy enough to actually receive the cure.
It just shows how fast the science is moving. Medicine is rarely a clean X-ray with a jagged white line. It's a constantly shifting ecosystem. Trying to screen for these infections while protecting the patient is an incredibly delicate act of biological timing and critical thinking. Thank you so much for joining us on this deep dive. Keep asking questions, keep looking beneath the surface, and we will catch you next time.